Hello everyone, myself Dr. Harsha. We all know that we have last time in the last class we have studied basics of biochemistry, that is metabolism of amino acid, carbohydrates and fats. So now let's begin with our inborn error of metabolism, starting with organic acidemias. So before starting this topic in depth, let's study regarding metabolism of branched chain amino acid. So in general, in the last class we have discussed metabolism of amino acid, where there is what? First step is transamination followed by deamination, then it mixes with glutamate and glutamine is formed. So likewise, we know that we have so many different types of amino acid, essential, non-essential. So these branch chained amino acids are essential amino acids. What are essential amino acids? The essential amino acids are those which cannot be synthesized from our body. They should be supplemented through diet. So for example, for metabolism of leucine, isoleucine and valine. So this is a simple crisp metabolism where leucine is degraded to produce what? End product acetyl CoA. There are so many enzymes, right? So there are so many steps. Leucine is degraded to isovaleric CoA, methylcrotonyl CoA, methyl glutaconyl CoA and 3-hydroxy 3-methyl glutaryl CoA. End product is acetyl CoA. Isoleucine is metabolized to form acetyl CoA and propionyl CoA. Valine is metabolized to produce propionyl CoA. Further, propionyl CoA is converted into methylmalonyl CoA and the end product is succinyl CoA, which enters into the TCA cycle. So just remember this metabolism of branch chained amino acid. So there are so many enzymes involved for the metabolism. Okay. So this is simple diagrammatic depiction of the metabolism. So if you want to investigate a case which enzyme is involved, in depth you want, you have to refer this chart or else not required. So just remember, leucine is first converted into alpha keto isocaproate and methyl valerate isoleucine, then valine is converted into keto isovalerate. So leucine, we all know that in transamination reaction what is happening? The amino group is removed and it is added to another keto group and the amino acid is converted into keto group. So this keto group, that is alpha keto isocaproate. So there are so many several enzymes regarding, according to that there are so many metabolic disorders. So what are organic acidemias? So now let's start in depth regarding organic acidemia. So what are organic acidemias? Organic acidemias are nothing but if there is a defect in the or a deficiency of certain enzyme in the metabolism of either carbohydrate, either fat or amino acid. If there is a specific enzyme deficiency, that is going to lead to accumulation of organic acids. And most of these organic acids are what? Most of these organic acids are carboxylic acid. So it might be due to the organic acidemia can be mitochondrial disorders also. The enzyme deficiencies leading to formation of organic acids. So if there is a defect in the certain enzyme, there is accumulation of the certain substances. That accumulated certain substance can be toxic to the body, brain and all the tissue, or this substance can be converted into another substance which can also be harmful to the brain. So this is same, that is amino acids, carbohydrate, fatty acid metabolism, neurotransmitter metabolism and what you call as purine and pyrimidine metabolism will lead to accumulation of the organic acids. Even certain drugs, diets, nutritional deficiency will lead to accumulation of organic acid. So what are the common organic acidemias? So actually for postgraduate student you will get a question also. So regarding organic acidemias. So what are the organic acidemias? Common organic acidemias are maple syrup urine disease, propionic acidemia, methylmalonic acidemia, glutaric acidemia, isovaleric acidemia. Less common are 3-methyl-crotonil-CoA carboxylase deficiency, HMG-CoA lyase, beta-ketothiolase deficiency and 3-methyl-glutaconic aciduria. So what are these? These are all what? Most of the diseases are due to defect in the breakdown of branched chain amino acid. So because of this, because most of the diseases are due to defect in the metabolism of the branched chain amino acid, in the beginning of the class I have started with the what? This flow chart. That is, if there is a defect in the metabolism of branched chain amino acid, that will lead to so many diseases: MSUD, isovaleric aciduria, methylcrotonil glycinuria, methylglutaconil aciduria. So these are all the disease. So just have a look. If there is a defect in branched chain alpha keto acid dehydrogenase, that will lead to maple syrup urine disease. If there is a defect in isovaleric-CoA dehydrogenase enzyme, there is accumulation of isovaleric-CoA which lead to isovaleric aciduria. If there is a defect in 3-methyl-crotonil carboxylase enzyme, that will lead to 3-methyl-crotonil glycinuria. So likewise 3-methyl-glutaconil-CoA accumulation due to defect of 3-MGC-CoA hydratase enzyme. Then last, that is 3-methyl-glutaril-CoA lyase enzyme, that is HMG-CoA lyase enzyme deficiency will lead to accumulation of this methyl-glutaril-CoA substance. If there is a, for example, in the metabolism of isoleucine, what is going to happen? It is producing acetyl-CoA and propionyl-CoA. If there is a defect in propionyl-CoA carboxylase, there is accumulation of propionyl-CoA. And there is something called as beta-ketothiolase. This enzyme is involved in the metabolism of isoleucine. So these are all the disorders. So most common and less common. So in this series, we are going to learn more of organic acidemias caused due to defect in metabolism of branched chain amino acids. So let's begin with first disease, that is maple syrup urine disease. It is an autosomal recessive disorder caused due to what? Caused due to deficiency of enzyme branched chain alpha keto acid dehydrogenase complex enzyme. So because this is the first step, branched chain alpha keto acid dehydrogenase complex, this is deficient, what is going to happen? There is, this enzyme is involved in the metabolism of leucine, isoleucine as well as valine. So if there is a defect or deficiency of this enzyme, there is a probable chance of accumulation of what? Alpha keto isocaproate, beta methylvalerate and keto isovalerate. And there is also in the blood you will find excess leucine, isoleucine and valine. So this is the first enzyme which will lead to MSUD. And this enzyme is a complex enzyme, like it is not simple one. It has three components like E1, E2 and E3. It also requires so many cofactors like thymine pyrophosphate, lipoic acid, FAD, NAD and coenzyme Q. So this requires all these cofactors. It is a not simple enzyme, it is a complex enzyme. Now coming to the types of MSUD, it depends upon what I have told. There is a enzyme deficiency. Depending upon how much percentage of enzyme is working? According to that, it is classified into several types. In classical, the enzyme activity is only less than 2%. Intermediate, also called as mild variant or mild phenotype, the enzyme activity is about 3 to 30%. Intermittent, here the child is fine, but if there is some catastrophe, some catabolic event, some stress factor is there, at that time the child will be having that acute catastrophic episode. Child might go for encephalopathy. So the child is normal between the illness. There is something called as thiamine responsive type of MSUD, where the enzyme is partially deficient. Sometimes the enzyme is up to 40%. So what is happening in this? I have told the enzyme is complex enzyme. It requires cofactors like thiamine pyrophosphate, lipomide, FAD, NAD, coenzyme Q. So it is like a mild variety only, but if you give thiamine in some patients in a mild phenotypic variant, the child will be responsive to thiamine. So the recovery is good with the thiamine. So they have given a separate entity that as thiamine responsive. Next, E3 deficient. So I have told this enzyme is having three components: E1, E2 and E3. E1 is having what? E1 is having two subtypes, alpha and beta. E2 and E3. So here there are names, that is dihydrolipol transcyclase, dihydrolipol dehydrogenase, okay, decarboxylase. So they have given a separate classification for E3 deficiency. So this part is deficient, that is E3 deficient. So the same thing what I have explained is, first step is what? Leucine, isoleucine, valine, transamination is happening. They are converted into alpha keto acids. So if then these alpha keto acids are, with the help of this enzyme, they are further degraded. Because this enzyme is absent, this leucine, isoleucine and valine are accumulated in the body, which are toxic. What is the clinical presentation? So I told, in the classical variety or severe variety, the enzyme levels are less than 2%. Because there is no enzyme activity, the severity and presentation will be early, and it is much severe as compared to the other variant. So what is happening? This variety is going to present in early neonatal period. Why neonatal period? Because the enzyme is very much less, that is less than 2%, and most of the IEMs, for example this MSUD only, usually what happens, there would be a baby will be fine for about 48 to 72 hours after delivery. On third day, especially third, fourth day, the baby will be like, they'll come with encephalopathy, poor feeding, vomiting. Why? Because immediately after delivery, when the mother starts breastfeeding, these toxic metabolites will get accumulated, and after 3 days, that is on the 72 hours of life, they will coming with a deteriorated condition, like with complaints of poor feeding, vomiting, irritability, lethargy, alternating hypotonia and hypertonia. So usually what happens in this case, the baby will be having more tone, like there is alternate episodes of hypertonia followed by flaccid hypotonia, like bicyclic movement, boxing. The child might throw scissors, coma, and there is something called as characteristic odor in the odor of the urine as well as earwax. So usually earwax odor it presents very much early. Then this is called as what? Burnt sugar. So when you burn the sugar, you might have come across the sugar factory, right? When you are passing just a side by to the sugar factory, you'll experience a very much pungent odor. The untreated cases might progress to respiratory failure and death. So why this happens? So I have told, the baby will be fine for 2 days after initiation of breastfeeding. On third day, because of the accumulation of all these metabolites, the baby will present on third day, fourth day, fifth day with acute encephalopathy. So the baby will be fine in the mother's womb, right? The baby might be good weight also, 3 kg, okay, normal well baby. So why the baby is well in the mother's womb? Because all the toxic metabolites are handled by the and removed by what? Placenta. So the placenta act as a dialyzer for the baby. So that's why there is no presentation in the womb. So when the baby is born, it looks like a healthy baby. So what is the manifestation? So how this works? There is something called as leucinosis. So the Nelson has used the word leucinosis. So what is this leucinosis? I have told there is accumulation of leucine, isoleucine and valine. Among all these, the most toxic is leucine. So the leucine, especially the leucine is converted into alpha keto isocaproic acid, that is its keto group. So this is very toxic compared to the other metabolites. So what happens? There is a raise in the leucine level. What is going to happen? There are so much of leucine is there, isoleucine is there, valine is there. As you all know that there is a blood-brain barrier. In blood-brain barrier, you have some transport system here, that is LAT. LAT is nothing but L-type amino acid transporter. So these transporter will transmit the amino acids to the brain from the blood. Because there is excess leucine, what is going to happen compared to, in this case, in this enzyme deficiency, compared to valine and isoleucine, leucine is very much in excess. So what it does, it competes with the other amino acids to enter into the brain. So it uses this. So usually other amino acids like phenylalanine, tryptophan, threonine, methionine, tyrosine, valine, isoleucine, histidine. So these also should enter to the brain for proper functioning of the brain. Because it is in excess amount, it is not leaving them to enter the blood-brain barrier. What will happen? Because tyrosine is responsible for the formation of dopamine, there is a less entry, there is a decrease in dopamine synthesis. Because tryptophan is responsible for serotonin synthesis, there is a because of decreased entry, there is a less serotonin. And the other large neutral amino acids also enter the brain for protein synthesis. So that will also what? That competes with these other neutral amino acids also. So this will lead to what? Leucine will enter the brain, it will cause encephalopathy. How does it cause encephalopathy? I told alpha keto isocaproate, what it causes? It causes disruption of the mitochondria. Because mitochondria is a powerhouse of the cell, it produces ATP. What is happening? There is a astrocyte dysfunction. And it also inhibits oxidative phosphorylation. So this is oxidative phosphorylation is required for ATP synthesis. And it also disrupts the glutamine metabolism. So there is a astrocyte dysfunction. Then because there is no ATP production, what is happening? There are so many sodium potassium ATPase, that is ATP dependent sodium potassium ATPase pumps are there. Because there is no energy, this will not function properly. So the toxic accumulates will have a osmotic effect, and there is an entry of water into the brain cells that will lead to what? Cerebral edema. So this will lead to what? Encephalopathy, which is called as leucinosis. Then what diagnostic test you want to do? Because I told there is a excess keto acids in the blood. So that the blood, they also come into the urine. So you have to do a test, dinitrophenylhydrazine test, which tests for keto acids. Because the keto acids are much higher in the blood, they also get secreted in the urine. So if you put this reagent, if the test is positive for ketone bodies, it produces a yellow-white precipitate. So it is a screening test for ketone bodies. Then urine organic acids, that is elevated branched chain keto acids. Then plasma ammonia acids levels you have to check. You all know that there is an increase in the level of leucine, isoleucine and valine. And again one definitive test is there. that is called as measurement of alloisoleucine, which is a diagnostic of this MSUD, because this alloisoleucine is nothing but it is a stereoisomer of isoleucine. It is usually not present in the blood. Because it is in excess amount, it is converted to alloisoleucine. So this is more specific. What confirmative test you want to do? You can go for a enzyme activity testing, that is molecular genetic testing, test for the enzyme activity. So this is branched chain keto acid dehydrogenase enzyme alpha. Do for beta also. This DBT is nothing but E2 component. DLD is nothing but E3 component. So these are all diagnostic tests. So these are all diagnostic tests. So hope I am clear. So now let's start with treatment. So what is going to happen? Because these are branched chain amino acid, whenever there is a stress or the newborn period, classical thing, there is a catabolism, there is a breakdown of the branched chain amino acid. So what you have to do is you should stop the catabolism of the amino acid. How you will stop? You should stop the protein intake temporarily, and then you have to provide a high calorie therapy in the form of IV dextrose and IV fluids. Then what you have to do is you have to correct dehydration, lactic acidosis, electrolyte imbalance. Then you should rapidly lower the plasma leucine. So you should restrict the branched chain amino acid. So sometimes you will get branched chain amino acid free formula feeds also. Then you have to supplement with isoleucine and valine. So because there is an excess of isoleucine and valine, already there is a defect in the enzyme, but still Nelson is recommending to supplement some amount of isoleucine and valine. Why? Because I have told the most toxic thing to the brain, or what is the haphazard is caused by what? Leucine itself. So if you give isoleucine, if you restrict completely all the 3 branched chain amino acids, these are the essential amino acids. So if you don't give essential amino acid, that will lead to what? Poor development and growth. And if you give isoleucine and valine, what is happening is there is a excess leucine in the plasma compared to the other isoleucine and valine. Because if you are supplementing some amount of isoleucine and valine also, what is happening? There is a anabolism. So they are going to form protein rather than catabolism. So isoleucine plus valine plus leucine, that will lead to what? Protein synthesis rather than degradation. Okay. Then if there is a severe encephalopathy, you have done everything because there are high leucine level. If there is a poor response to medical therapy, go for hemodialysis or hemofiltration. Then treat precipitating illness, that is infection. What is the precipitating cause? You treat first. So the therapy is you have to lower the leucine level. If there is a cerebral edema, not only that, if there is a cerebral edema, you have to treat the edema measures also. Okay. For example, not classical type. If there is an intermittent time, child is fine, 2 years old, 3 years old, in newborn, anti-edema measures are not required because already the AF is open. So 3-year-old, 4-year-old has come with encephalopathy, give anti-edema measures like mannitol, 3% NS. Okay. So treat and there is also what? Hyperammonia in these conditions, that is organic acidemia. Why hyperammonia? Most of the organic acidemia will also have what? Hyperammonia, because we know that half of the urea cycle is taken place in what? Mitochondria. So initial some 2 steps, I think they are taken place in the cytosol, but most of the this thing is taken ammonia, which is converted into urea. It is taken place in what? Mitochondria. These toxic products, they also what they do? What they do is they will cause mitochondrial dysfunction. So because of that mitochondrial dysfunction, there is a accumulation of ammonia also. Then you have to take measures for removal of the ammonia also. So treat hyperammonia also. Then long-term treatment. So when the acute phase is over, what you have to do is, after the settlement of acute phase, then you have to plan for a long-term strategy. So lifelong dietary restriction of branched chain amino acid, and also you have to provide what? You have to provide this branched chain amino acid free formula, supplement with the valine and isoleucine. Why you want to supply with valine and isoleucine? I have told. Another thing is, if you restrict this essential amino acid, there is something called as, it resembles a clinical picture of acrodermatitis enteropathica. Acrodermatitis enteropathica. So, and also you regularly monitor the level of plasma leucine, isoleucine and valine. Also monitor growth and neurodevelopment. If there is a sick child, please do supplement with high calories with glucose, IV dextrose, because you want to prevent the catabolism. Yes. Then in some cases, liver transplantation may be helpful for metabolic stability. So just want to give a quick brief idea for different types of MSUD. Classical presents in the newborn period or infantile period. So here is a case scenario where a 7-day-old male neonate, term baby, birth weight of 3.2 kg, normal delivery, cried immediately after birth, exclusively breastfed, discharged on second day of life. There are no significant antenatal and perinatal complication. But on day 5 of life, the baby has developed poor feeding, recurrent vomiting, excessive sleepiness and weak cry. So next 24 hours, mother noticed reduced activities and stiffness and abnormal movements also, and one generalized episode of seizures. And by this time, parents also noticed some sweet smell of urine and of earwax. So on examination, what you are seeing is the baby is lethargic with poor neonatal reflex. So vitals mild tachycardia. On neurological examination, there is a hypertonia, intermittent opisthotonous position. So this is also important. In the newborn period, the baby will present with what? Hypertonia. That is alternating with hypotonia or flaccidity, and sometimes it also produces with what? Opisthotonous. What is opisthotonous position? That is arching of the back. Where you will also see this opisthotonous in what? Strychnine poisoning, tetanus, condition also you will see opisthotonous. So boxing and bicycling limb movements and depressed neonatal reflex. So how this condition is mimicking? The first diagnosis should be what? Sepsis. It mimics neonatal sepsis, and most importantly it mimics meningitis. When you are treating, still the baby is not responding, you can think of other diagnosis like IEM. So you will have a proper history, that sibling death or abortion or consanguineous marriage history. So you have to take a detailed antenatal history. So the mild type usually they don't present in the newborn. So most of them, they don't present in the newborn period. They present after like 2 years, 3 years. What is happening? Here also in this, the patient is having normal birth, normal growth until infancy. Then what had happened? There is a mild delay in speech and learning, and the child has mild intellectual disability also and seizures also. So till 3 years child is fine, but these are the things where mild delay is there, intellectual disability is there, seizures history is there. So what happened? The child had some respiratory tract infection, upper respiratory tract infection, followed by which the child has developed poor appetite, recurrent vomiting, lethargy, unsteady gait and seizures, and mother has noticed sweet, that is burnt sugar odor from the urine. So this is what? This is mild variety, or what you call it as intermediate variety. Next is intermittent type. Intermittent type, the child is perfectly fine. Here there is a 4-year-old child, normal birth, normal neonatal events, growth and development also normal, no previous neurological illness. The child is tolerating the diet well. There is no symptoms until the current illness. But here also some acute event. For example, same febrile respiratory infection is there, presenting complaint. So suddenly after 2 days of upper respiratory infection, child has developed vomiting, increased lethargy, unsteady gait and progressive drowsiness. So this is regarding what? Intermittent type. Next is thiamine responsive. Thiamine responsive I have already discussed. Yes, I told it is nothing but a milder variety where it is responsive to thiamine. Why thiamine? Because thiamine pyrophosphate is a cofactor for that, what you call branched chain alpha keto acid dehydrogenase, right? Okay. So how much thiamine you want to give? Some cases might respond to thiamine as low as 10 mg per day. Some cases may require as high as 100 mg per day of thiamine, which will lead to a dramatic clinical and biochemical improvement. So next topic is isovaleric acidemia. So I have already discussed what is isovaleric acidemia. So let's move to the first slide. So that's why I have started with what? Metabolism of branched chain amino acid. So what is happening here? Here also leucine, isovaleryl CoA I have told, right? So this is due to what? This is due to again defect in the metabolism of leucine. What is happening here? So what is happening here? Isovaleryl CoA is there. This is the sequence: leucine, alpha ketoisocaproate. This enzyme is there, BCKDH. Then isovaleryl CoA is formed. If this enzyme is deficient, isovaleryl CoA dehydrogenase, this is getting accumulated. So this is not seen in isoleucine and valine. This is purely due to defect in what? Defect in leucine metabolism. So it is also autosomal recessive. Here there is accumulation of what? Leucine, and the prevalence is what? 1 in 62,500 to 2,50,000 live birth. So same what I have explained, it is same only. So what are the accumulated products? It is not that a single product is accumulated. For example, what is happening? Isovaleric CoA is this thing which has to be metabolized to 3-methyl-crotonyl CoA. This enzyme is defective. So what is getting accumulated in the blood? Isovaleryl CoA and leucine. This isovaleryl CoA can be converted to what? Isovaleryl carnitine also, which is called as C5. Then other isovaleric acid derivatives also. Then isovaleryl glycine also. It combines with glycine to form isovaleryl glycine. And this can also combine with hydroxy group to form 3-hydroxy isovaleric acid. So the clinical presentation is what? Here the child is having poor feeding. So the presentation also depends upon the how much the enzyme is deficient or how much the enzyme activity is present. So it can be asymptomatic to severely symptomatic. So whenever there is a catastrophic event, some stressor, some infection, some event, then the child might present. Otherwise child might be normal also. So we don't know. So severe infantile presentation, that is poor feeding, recurrent. So here the clinical thing is that in isovaleric acidemia the child have severe vomiting, dehydration, metabolic acidosis, lethargy, convulsion, okay, hypoglycemia, hypocalcemia, bone marrow suppression, because this isovaleric acid, it suppresses bone marrow also, which lead to what? Pancytopenia. Then if it could lead to death also if there is a delay in the treatment. So because there is a severe vomiting in the newborn, like within 1 month, so it may mimic like what? So usually what we will think, if the 1-month-old child is coming with severe vomiting, the first DD what we think is pyloric stenosis. So it is mimicking like pyloric stenosis. And what is the characteristic odor here? There it was a burnt sugar. Here it is what? Sweaty feet odor. Sweaty feet, right? And it is also called as what? Rancid cheese odor. Rancid means what? So rancid cheese odor or sweaty feet. Okay, sweaty feet andre matte ನಾವು ಸಣ್ಣವರಿದ್ದಾಗ what we call, when we were small, when we used to go for a computer lab, Because of that socks we used to get smell. Sweaty feet, right? Pungent odor. Then intermittent or a milder variety. So this is precipitated by what? Infection, dehydration, surgery, high protein intake, fasting or catabolic state. So episodes may resemble diabetic ketoacidosis, and some patient may present with recurrent acute pancreatitis. Okay, why hypoglycemia? Already have in the first basic lecture I have discussed. There are so many amino acids which are gluconeogenic, right? If there is a defect in the metabolism, they are not going to produce the end product which will lead to formation of glucose or acetyl CoA or ketone bodies. So our body is what? It is working as a team, rescue team, healing team. So it is like a overall well functioning machine, I think. Okay, so it is like a team. So as we tell nowadays, Gen Z, and what they'll tell, we are independent woman, we are independent male. There is nothing called as independent. What I feel is our body is only working in a interdependency. So we are also what? We are also interdependent, right? So that's why you have hypoglycemia, hypocalcemia, hyperammonemia. So what are the lab investigations? So when you go for a basic investigation, whenever there is a child is encephalopathy or anything, what the first basic investigation, we go for a blood gas, right? So there you will see metabolic acidosis, and the metabolic acidosis will have a high anion gap. And when you go for a urine test for ketone bodies will be positive. Plasma ammonia, I have told already, there is a severe hyperammonemia in case of organic acidemia. I have already explained why there is a hyperammonemia. Then blood glucose, hypoglycemia, and serum hypocalcemia. I have already told, because it suppresses bone marrow, you will have a picture like pancytopenia, right? So if a newborn baby, 7 days, 10 days, 12 days baby is presenting with pancytopenia, our mind will be thinking it could be sepsis, because the blood parameters are having pancytopenia. First DD what we think is sepsis. So there is something called as acyl carnitine profile. I have already told. C5, that is isovaleryl carnitine. So this is elevated in the plasma. And this isovaleric acid and 3-hydroxyisovaleric acid, these are present more in urine. So what is going to happen? Because it is more present in the plasma, when you go for a what? For TMS screening, that is dried blood spot, when you are testing, so you should, if you are detecting increased C5 level, that is isovaleryl carnitine, suspect isovaleric acidemia. Confirmation is genetic testing. Management same as MSUD. So treat the catastrophic event, supplement with IV glucose, IV fluid, stop protein intake for 24 hours or till the acute episode is resolved. Then if there is acidosis, give supplement with sodium bicarbonate, temporarily restrict protein. Here you can give L-carnitine also. Why? Because isovaleric acid is formed, it combines with carnitine, isovaleryl carnitine, which is excreted in the urine. So supplement with carnitine, it is a scavenger, it is removing the acid from the blood and it is getting excreted into the urine. So give 100 mg per kg per day oral carnitine. Then glycine also, some center uses 250 mg per kg per day of glycine. Why? Because it enhances conversion of isovaleryl to isovaleryl glycine, which has a high urinary clearance, right? Whenever you suspect isovaleryl, the cocktail regimen what we put, you can give glycine also, you can give carnitine also. Then treat hyperammonemia. Yes, I've already told, if the blood glucose, ammonia level is more than 200 micromillimole per liter, you have to treat hyperammonemia, because there is so much of acidosis. Even after medical measurement, still it is not getting subsided, or the acute event has not come in control. Go for a renal replacement therapy. Long-term management, avoid fasting. Yes, what is happening whenever you are fasting? All the glucose, if there is a fasting, hypoglycemia is there, the body will try to regulate the counter system will activate. So there is all catabolism, like protein is getting divided, lipid to produce energy. What is happening? There is a amino acid metabolism, then fatty acid beta oxidation. So better is avoid fasting, so that catabolic events are avoided, and during infection, dehydration, surgery, or some acute event, be careful. So that should be managed very properly. Then long-term supplementation of carnitine, regular development of growth. Then genetic counseling and family testing is also very much important. And you have to look for normal development. So here is a case scenario where 10-day-old male infant present with poor feeding, hypotonia. So I have told in MSUD there was hypertonia followed by hypotonia. Here where is the child is very much lethargic and hypotonia, and he was a full-term newborn with no complication. On examination he is hypotonic, difficult to arouse, and there is a distinctive unusual odor. What kind of odor it is? Sweaty feet odor or a rancid cheese odor. So it is mimicking what? Isovaleric acidemia. So thank you for the patient listening. So next class I will be dealing with the next set of IEMs. I will be dealing with the same organic acidemias only. Next part like propionic acidemia, methylmalonic acidemia, multiple carboxylase deficiency. So further I will be discussing. Thank you for the patient listening.